Welcome everybody. It must be the first Tuesday of the month. This year it's October the 1st. It's 5 o'clock Central Time, and we have a really interesting discussion to share with you today. This started when I was talking to Sandy Schremeyer. As some of you know, she's the administrator for the Facebook site. And we were talking about guests to have on, and she said a lot of people have interacted or heard about Dr. Fahed, EP with the DeBakey Heart and Vascular Center. Would it be possible to have him on? And I said, well, I don't know. Let's find out. So I asked Joe, and he was kind enough to join us this evening. We come to you from Houston, from Methodist Hospital, from the DeBakey Heart and Vascular Center. And this is an hour of AFIB discussion. If you would like to join the discussion, we are happy to take your questions. Please do so by one of two means. If you're on your phone, you go to 37607 and then text the word DeBakey, and we'll show you see that on the screen. If you're on your computer, go to pollev, that's POLLEV.com, enter DeBakey, and then respond to the activity. This is a wonderful time for you to ask questions about AFib, because you'll have Dr. Fahed here, and I'll be here as well. So hopefully between the two of us, we can cover most of your questions. I can't guarantee you we have all the answers. Electrophysiologists have been working on AFib for the last 26 years since Dr. Hastiger reported his experience, and we're still working on it. But we'll do our best to answer your questions. Let me introduce why you're putting in more questions for us. And by the way, don't wait to the end of the hour to put your question in. You're much more likely to have it answered if you ask it towards the first 15 to 30 minutes of this program. And we'll be here, it's at 5, we'll be here till about 6, and then we have to end the program. I met Dr. Fahed here at DeBakey Heart and Vascular Center, Methodist Hospital, Texas Medical Center, Houston, Texas. Shortly after I came here, which would have been around, I think, 2019, he's got a very good pedigree. He trained in cardiology at Boston, at University of Mass, and then he went to arguably one of the best premier programs for electrophysiology in the country, the Ivy League program at University of Penn. So when he came to Houston, he was very well qualified. You may ask, why did Dr. Fahed come to Houston from the East Coast? I'll let him answer that for you. He has been an electrophysiologist here now since 2017, and he takes on complex cases. He is kind, he's compassionate, and I think he truly understands the dreams of people that have AFib, and that is, you want some hope. You'd like to think that maybe, even though maybe you've been told you'll never be in rhythm again, or you'll always be on blood thinners the rest of your life, but he understands the hopes and dreams and understands that people want to find a way to get off blood thinners, to get back in rhythm, get off medications. So it's been really an honor and a pleasure for me to work with Dr. Fahed over these last 5 or 6 years. Again, I'm going to put it up here one more time. If you have a question, it can be either an EP question or a surgery question. It doesn't matter. Please, if you're on your phone, go to 37607, text the word DeBakey, and then you respond to the activity. Or if you're on your computer, go to pollev.com, enter DeBakey, and ask your question. There are no bad questions at all. We understand you're not physicians, you're not surgeons, you're not electrophysiologists, so there are no bad questions. So with that short intro, I'd like to introduce you to Dr. Joeseph Fahed, who is kind enough to join us in the studio here. Joe, welcome to the program.
Thank you, Dr. Wolf, and good to see a lot of you here. It's a great honor for me to share this discussion with you, and I know some of you.
That's right.
Over the years, I've been working with Dr. Wolf maybe for 4 or 5 years now, And we had so many. I've been with him into the OR, and he's been into the cath lab, and we shared so many maps, so many cases, difficult, complex cases together. We have a good work plan for a lot of the patient that come through, and it has not been easy, but it's been amazing.
Well, I have to be honest with the audience. I send Dr. Fahed some pretty difficult cases, people that have had multiple interventions that have been failures, and we ask him to sort of be the cleanup hitter and figure it all out. And the amazing thing is you've been able to do that in so many cases, which is fantastic.
Yeah, well, you do the heavy lifting for me with your procedure, and I'll go clean the rest. But yeah, over with the experience we built, I developed a plan and stepwise approach. And there's only so many places the flutters or the AFIB can emanate from, and I'm thankful and blessed I was able to help so many of you out there over this time.
They appreciate it. Let's start out by taking a few questions. We'll clear the board a little bit. The first question's for you, Joe. Does Dr. Fahed require an anticoagulant after a catheter ablation for flutter, and if so, for how long?
So the answer is yes. I'm going to talk in general for the typical flutter without the mini-maze surgery. The guidelines in general, 3 to 4 weeks of anticoagulation. This is a de novo new flutter. For atypical flutter after previous catheters, ablations, or mini-maze, I usually require 3 to 4 weeks as well of anticoagulation. And here's the reason, because immediately the patient would be, but I have my appendage clipped. The reason is, with our catheter ablations, we do place some lesions inside the atrium, the endocardium of the atrium. I don't want those lesions to cause some charring or thrombus that can go to the brain, patient gets a stroke. So that we believe the healing takes about 3 or 4 weeks over there. And indeed, I haven't had anyone who had a stroke after with this. Well, yeah.
Now let's see. The first question, and Mr. Producer, I only see part of the question. I don't see the whole question. If a patient is tolerating rhythm and rate control meds and hasn't, but I don't see the rest of that question. Is there more to that one? I can't tell. See if you can open that up, expand it. No.
Went away. Oh, it hasn't. That's how it stops.
Yeah. So I'm not sure if you know who you are who sent that in. Give us a little more information, because I don't think we received the whole sentence. If someone is 9 months post-op mini-maze, still having flutter, what is the criteria for determining if they need an ablation?
I'll take this one.
Yeah.
So there's this blanking period. It differs a little bit between catheter ablation and surgical ablation, but it should be somewhere between 3 to 6 months. I believe if there's arrhythmias happening beyond the 6 months after catheter ablation or a mini-maze, we should start discussing another procedure if you want to get off medications. Otherwise, you have to be on antiarrhythmics and medications and side effects and the whole thing. So I think, do you agree cutoff 6 months roughly is
To me, I think it also depends on what their burden is, because a lot of these patients have a implanted loop monitor. Now, here's an example. Sandy Schremeyer, who's the administrator for the website, she had 3 ablations. I don't think she'll mind me saying this, because she said it on the Facebook site. She'd had 3 ablations. She was told there wasn't anything else for her to do in her state. It wasn't here. And then she came and had the mini-maze, and she did have flutter for about a year. And then it finally, but it wasn't a real high burden. So I wonder if sometimes the burden matters too. Her burden was tolerable, it wasn't real high, and it kind of burned itself out. So I think it can happen.
Anything with the low burden, in my opinion, and does not affect the lifestyle, we can wait.
Yeah.
Like if we're talking about 1%, 2%, there's no rush to do an invasive procedure. Every procedure has its own complications, even they're very low, even though we are very experienced. We've done thousands of those cases. Every case is an intervention. So if the burden is low and the patient is not in and out the hospital or heart failure, I think, yes, of course we can wait. And there's few patients you sent my way or went through to me, they have very, very low burden, 0.1%. And I was like, you don't need to have anything done. It's 2 minutes here and there. You don't need an invasive procedure.
That happens sometimes.
And maybe this is all what they needed to hear, or another opinion.
Well, and I feel the same way as you. Is if someone's had this surgical procedure, I generally tell them to wait 6 months to a year. But also, if they've come to me and they've had the catheter ablation, and they're less than 6 months to a year, I say, wait, maybe things will settle down a little bit.
Correct.
Don't be in a rush. And it also depends on the medication too, right? If they're full-bore antiarrhythmic and they're still having it, well, wean yourself from the antiarrhythmic and see if you're really in bad shape or not. Sometimes we do that, right? So you have to establish a baseline, and you have to have a period of time, and you have to have a certain burden.
I agree with the burden part. We don't know exactly the answer. So the 90 days blanking period in catheter ablation, it started in the studies. Now we know which some people change to 8 weeks, and some people change now to 6 weeks. In other words, if you have your first AFib recurrence beyond week 6 or week 8, the chances of AFib coming back is a lot higher than the first or second week post-ablation. But for research purposes, because you need to have the same definition for all the research and the paperwork, the blanking period is still at 90 days. We know when on practical, if I have a patient on day 89, he had the AFib recurrence, and then I had to cardiovert him, most likelihood within the next year, he's going to have more than one recurrence, and more likelihood I'll start, at least in my mind, or talking to him, we may consider you need another ablation or another intervention, because that vein probably reconnected or some tissue has reconnected.
Now, on the surgical side, I think it's worth mentioning that it's not unusual for someone who's been out of rhythm for a year, who has a mini-maze procedure, still be out of rhythm. It could be a left-sided flutter, it could be AFib, and we always want to try at least one cardioversion. Do you agree with that? Because sometimes that takes care of it.
200%. That's all it needs sometimes.
Yeah, so you don't want to jump from a failed procedure on either side if you're out of rhythm and you haven't at least tried 1 or 2 cardioversions.
At least. So I give, lately, I don't know how sure I get, I gave the example of my hand. If I burn right now any surface area, there's so much inflammation and burning and vesicles. And this what happened either inside the heart or outside the heart. So it takes that burning to settle, to scar out those 2, 3, 4 months, and then do your cardioversion, and then see what's left and to deal with it. So that's how it is. That's
on the surgical side, we know from many, many studies that the peak inflammation, if you cut yourself, if you break a bone, the peak inflammation is at 21 days.
Yeah.
That's 3 weeks. Yeah. That's the peak.
Correct.
So things, to your point, things have to have time to settle down. Yeah. And then do a cardioversion, and then see. If they fail 2 cardioversions, okay, then they probably need something else.
I have someone also came through your group. He did fine, long-standing persistent, so AFib for more than a year. And he did fine for 18 months, no medications. And then he had 1 AFib episode. And he came for catheter ablation. I was like, let's try a cardioversion first. I don't know what triggered it, a virus, I don't know. And so he had a cardiovert locally. I was like, call me back if it comes back. And so far, it has not come back. Just to say, very rarely this may happen one time. It doesn't mean it definitely will recur or come back or you need an intervention.
There was one of my patients who was 16 years out from the mini-maze, did very well, no episodes. He got COVID. 3 days later, he went out of rhythm.
There you go. Yeah.
Sort of the same thing. Yeah. Some new myocardial inflammation episode, and we know that the virus and maybe even the vaccine can cause myocardial inflammation. Correct?
There's a lot of theories about it, and patients ask me all the time. I have one patient who literally never had AFib, and he got first vaccine. 2 weeks later, he got AFib, shock. Second vaccine, 2 weeks later, another, again, AFib.
Oh,
so I can't argue with this.
Yeah.
But here's what I can say. Millions got COVID and millions got vaccines, hundreds of millions. We have not seen a peak in epidemic of AFib. Yeah. So this argues against the fact that overall it will cause or may cause, because we need to be careful over here.
It's called true, and unrelated.
And unrelated.
True, you had the vaccine. True,
yes.
You have AFib.
Correct.
Doesn't necessarily mean they're causally related.
And maybe for that one person that you mentioned, I mentioned, and that individual person maybe. But when we zoom out and look at the body of evidence, there's no direct correlation. Even the myocarditis risk with COVID was very low, 1/7 in 1,000 or so.
Here's a question for you. What is your opinion on IV Sotalol loading versus PO loading?
So IV Sotalol recently came to market. It's a very expensive drug, the IV part of it. And it started initially to do the load over 24 hours. Then now we have accelerated protocol. Over here we can do it over 4 hours, all the way down to 4 or 5 hours of observations. The load over 1 hour, watch them 4 hours later. I don't have any preference. Sotalol in particular, half of the EPs can do as an outpatient, and the other half as an inpatient, unlike dofetilide or ticosin, where it's mandatory to be as an inpatient for 3 days. In my practice, I do as an outpatient. I start it slow and increase as needed, and bring them on day 3 for an EKG, and then later on. In terms of pharmacology, there's no difference in terms of the level in your system, in your body, IV versus PO. So there's no difference. They're both forms of the same medication, same efficacy, same safety as well.
So you don't think it's a great medical breakthrough then, huh?
It's made for the EP or for the doctors who wants to do PO load over 3 days in an inpatient setting. It does save the hospital and the patient 3 days in the hospital, in that regard. But not all the doctors comfortable doing outpatient.
Hi, Dr. Wolf. I was wondering how you determine whether a follow-up ablation is needed after a maze and a flutter shows up. Well, we sort of started to touch on that.
We just
and I think just to reiterate, first of all, if the heart is not in rhythm a month after the procedure, a cardioversion is in order. That can be done close to where you live, or some patients come back to Houston for it. What's the difference? The difference is generally at home, if the EP is not familiar with what we do here, they may determine that the patient should be on a blood thinner for a month and should have a TEE. If it's a patient that I took care of here and I know I closed the appendage completely, I may not do the TEE, and I may not do the anticoagulant loading either. So that's one difference. So have a cardioversion and see if that takes care of it, and have an antiarrhythmic on board. For me, that's usually Amiodarone. The key is low dose. I use low dose, and I look at the patient. If the patient is thin, I don't use 200 milligrams a day. I use 100. Sometimes we use 50 a day, because we're not so concerned about getting the level up quickly. We just want a maintenance level. So I think some of the complications occur when you have to ingest so much over a short period of time.
And I do believe two things. One, at this dose, there's no toxicities associated with them. There's no long-term toxicities, because we always worry about the lungs, the thyroid, the liver. I don't think these are at these kind of doses. We're talking about 100 milligram every other day or something like this. Two, Amiodarone is probably, even though it has all this halo, the toxicities associated with it, is literally the safest drug for all the arrhythmias we have. Comparing to Sotalol, not only safest and efficient, but safe.
I have so many patients that are long-standing persistent. We put them on low-dose Amiodarone months before their procedure.
Yeah.
And they say, boy, my heart settled down.
Yeah. Yeah, I
some
do
of them go in rhythm, some of them don't, but almost all of them say it calmed my heart down a lot.
Yeah.
And if that happens, the chances of them getting a good result with the procedure is much higher.
Yeah.
So I think the key is the low dose.
Yeah.
And again, I tell patients it may take you 4 weeks, 8 weeks to get enough in your body to do something, but we're not in a rush.
Correct.
I think, why be in a rush? It's a chronic condition. It's not like appendicitis,
Correct.
where you got to take care of it tonight.
And they've been in AFib for 2, 3, 4 years.
Yeah.
I mean, nothing gonna change it within a week or two.
Take your time, use low
Correct.
dose. I talked to a pulmonologist. I said, when's the last time you saw lung toxicity from amiodarone? He said, I haven't seen one in 20 years.
Yeah, I've seen.
Have you seen it?
Yeah,
It
there's
must be
two types.
unusual.
So there's the chronic type, which we don't see as much, because back before patient would take it for 15, 20 years. And
Okay, well, yeah.
But then there's an acute reaction. Sometimes we can see it within a week or 2 or 3, and I've seen 1 or 2 in the last 8, 10 years. So it's rare, very extremely rare.
Yeah, that's right.
And
My rule is I really don't want somebody to take amiodarone much more than a year unless it's extremely low dose. And here's another phenomenon that I've seen. Now, this is anecdotal. It's not a study, but I've had a few patients that take a small amount of amiodarone, like maybe 1 200 milligram pill a week, and it helps keep them in rhythm.
And it does
and
the
they stop
job.
it,
Yeah.
and after a couple of months they go out.
Yeah, yeah.
Is that possible?
I don't know. I mean, amiodarone, I'm not sure how it works, but
Is it
I mean,
because the substrates changed and it's
Yeah.
not, I don't know.
I know sometimes they take just a little bit
Yeah.
to keep the edge off.
And then if the cardioversion on antiarrhythmic doesn't work, and we've tried it twice, that's usually when I call you
Yeah.
and say, can you evaluate this patient? And fortunately for us, not everybody does this, but Dr. Fahed's willing to do virtual visits with patients. Not everybody does that.
Try to accommodate as possible,
Yeah.
as much as possible.
Which is greatly appreciated. Not everybody does that.
I want to say one more thing about the amio before we move on, is the side effects that patient complain about or feel or tolerate, the nausea, the neuropathy, the fatigue, it's all dose dependent. Very important. So we cut down the dose in half, and those sides. It's not an allergic reaction where I cannot take it anymore. This is
It's not all or nothing.
It's not all or nothing.
Yeah.
It's dose dependent, especially the neuropathy and the GI side effects.
Is there a way to determine if a patient's left atrial appendage is shaped such that it would or would not be prone to having clots? You want to tackle that? So we're talking about the anatomy of the left atrial appendage and blood clots.
On top of my mind, the answer is no. I don't recall any study that looked at different shapes, and if there's 3 or 4 shapes, we usually go by the broccoli shape, the windsock shape, the chicken wing, and one more.
The 747 wing?
Today we're laughing about, I did the Watchman today. But anyways, all of this you can see there's a pouch, and whether it's broccoli, meaning the pouch is not deep, or in the windsock where the pocket is very deep, and this is where the clots form. Number 1. Number 2, the only way to tell the shape, not even a TE, maybe a CT scan with contrast. I don't think anyone would do such a study. But the answer is no. There's no difference in shapes. If you have an appendage, you're at risk of having clot. What the risk of clotting actually is with the chest to vasc and not by the shape of the appendage.
If you take any mammal, it doesn't matter if you're a rabbit or a squirrel or a human, if the blood slows down long enough,
In
it
one
will
area.
clot.
Yeah.
It'll clot.
Yeah, and this appendage is literally a pouch.
Yeah.
So it's gonna slow over there, and that's how it. Yeah, it's unrelated to the shape.
Dr. Wolf, many questions on taking CoQ10 and magnesium. What supplements do you suggest, and which should we stay away from? Well, this is not my area of expertise. What I generally tell patients is moderation. If you're going to take supplements, most of them are unproven, and some of them are very strong. And I have seen patients, I had a couple of patients who had AFib, they had the mini-maze, they did well, and then they came back a few years later and they looked terrible. But they were taking maximum doses of supplements, and I got them off the supplements and the AFib went away.
Yeah.
So at some point, it's too much of a good thing.
Yeah.
So for me, I say, go ahead and take what you want, but do it in moderation. Just because you think it's a good thing doesn't mean more will be better.
I personally not a big fan of supplements at all. The studies I prescribed, the medication I prescribed were all studied. The supplements over the counter, I have no idea what not necessarily the magnesium, but what comes with it.
Right. And some of them
The
are pretty
ingredients,
strong.
the ingredients, right?
Yeah.
And then I also worry about polypharmacy as we're getting older, and medications, our metabolisms, all these, I've seen patients, they take 2 prescriptions drug and literally 12 supplements. I don't think that supplement's doing anything for them, and I tell them that. Now, there's some supplements, may also, like for example, vitamin E, there's some evidence may increase some prostate cancer or something, but magnesium, there's no harm in taking it. We know that. And so it helps in CoQ10 as a cardiologist, it does help the cholesterol for statin intolerant patients. So those 2 are okay, but everything in moderation. But stay away from all the different vitamins. We don't need vitamins unless you're living you're vegetarian on a remote island for 5 years. You're not going to lose any of these vitamins in our body.
Yeah, it's written in many texts that if you receive 10 minutes of sunshine a day, that's enough vitamin D, enough for your body to make the vitamin D you need. So, okay, let's move on. What about those with overactive thyroid that can't take amiodarone?
Excellent question. So there's 2 types of amiodarone problem with the thyroid: the hypothyroid and the hyperthyroid. And the hyperthyroid, it can be thyrotoxicosis with autoimmune disease, and the hypothyroid. So if it was hyperthyroid, the question, the way it was asked, we should not give amiodarone. And that's type 1 and type 2, and this is endocrinologists will be involved in this. This is a contraindication for amiodarone. It's not worth it. We have alternatives, and we should not. The hypothyroid, however, if you are on levothyroxine for a while, and we start amiodarone, and now you notice your TSH is not as low or high, it's okay to increase double the levothyroxine from 50 to 75 or 100 is acceptable, but not in the setting of hyperthyroid. We should stop it.
So the answer is hypo, it's okay?
Correct. Hyper, we should
No.
not. And there's antibodies that the endocrinologist check for them to confirm the reaction. And if they have that reaction, we should not give amiodarone, 100%.
For those of you who don't know, amiodarone has an iodine in the center of the molecule, which is believed to be very important. There's only one other antiarrhythmic that sort of has the same molecular shape without the iodine in the middle, and that's Multac. But in my experience, it's not nearly as successful as amiodarone. It does have lower toxicity, but as we discussed, if you use amiodarone, you use low doses, then you're probably not going to see the toxicity anyway. So what I tell some patients, I said, yeah, Multac is maybe safer, but it doesn't work. You can drink a lot of water, and that's safe too, but it's not going to stop your AFib.
Just to, yeah. I mean, I only use, that's one indication for amio. I use it as a bridge to something.
Yeah, that's
and that
right.
bridge,
Yeah.
I mean, 3-4 months of amiodarone is probably the safest setting we can use it. We're not discussing about long-term amiodarone. We're not advocating amiodarone for everyone. It's a bridge for a successful ablation or healing from it, or minimally surgery and healing from
it. That's right. Let's put up the screen again. If you want to send us a question, we'll try to get to you this hour. If you're on your phone, dial 37607 and then text up in the text box, put DeBakey. If you're on your computer at home or wherever, go to pollev.com, POLLEV.com, enter DeBakey, and we'll do our best to answer your question. Here's another question. I have learned my AFib burden is low at this point. Is it true that AFib is a progressive thing? Dr. Fahed.
My answer is yes. I'm curious to see about your answer. But in my experience, unless AFib was triggered by something unusual, extreme sepsis in the hospital, or it only with time and only matures and get worse. It's always start paroxysmal, and then start the episode become more frequent, start longer, and then persistent and long-standing persistent. And here's the problem is, the later we wait, the harder it is for us to get rid or to find those triggers taken care of. It almost always starts with the pulmonary veins, as you know. And then with the long-standing persistent, which is the extreme, the other areas of the heart takes over, appendage, SVC, posterior wall. But the rate of progression is very different between patients. So it may take 10 years for someone to go from paroxysmal to persistent, or maybe take 2 years. And this is what the patient and the physician needs to be aware of.
I agree 100%. Same thing. Yeah, it's going to progress,
That's my experience.
but the rate.
Everyone's
and I think
different.
there are a lot of factors. Maybe I've seen people that had a pretty significant AFib. They decided to change their lifestyle. They lost 60 pounds, which is a lot to lose. Or they got into a different job that wasn't so stressful. And I think, I'm not saying that they stopped their AFib, but they changed the rate of progression. Does that make sense?
Yeah, so there's 3 actually lifestyle changes that's now proven to affect what you're talking about. Also, they help success rate of ablation by 5% each. One of them is weight loss, the 5 to 10% of someone's weight. 2 is test and treat for sleep apnea. But that's the first thing now. If you go to an electrophysiologist or AFib, the cardiologists say we have to treat you for. And 3 is treat hypertension. So untreated hypertension or uncontrolled hypertension is also. So if you address the 3 risk factors, we can help reduce the burden of AFib, increase the success rate of any intervention made on them each by 5%. And
maybe slow the progression.
And slow the progression, correct, significantly, correct.
Yeah, that's a good answer. Can one take amiodarone if you are allergic to betadine?
I mean, depends on the allergy to betadine, but it has some of those betadine or antiseptic that we use have iodine in it.
Yeah, betadine has iodine in it.
Yeah, but you may be allergic to the non-iodine component.
Well, I guess a related question is, can you have a CT scan with a...
which is the IV dye or IV contrast.
Right.
And experienced, yes. The answer is yes, you
usually
can.
It's yes.
But unless, again, the allergy is very particular, the allergic reaction is very particular to one of the components that is the same. Because the dye we use for CT scan, for cardiac cath, for all of this, I thought I silenced this, I'm sorry. They all have iodine in it, but we're able to do them without any cross reaction with the allergic reaction.
Now, sometimes I know here patients are pre-treated a little bit.
In any doubt, we always pre-treat. It's so easy for us to do.
Yeah.
But the question is about chronic amiodarone use, and unless you have very documented which allergen you're exactly component it's not to iodine, I think it's okay to take it.
All right. Does a patient have to switch to amiodarone before the Wolf mini maze if flecainide and diltiazem are keeping the patient in rhythm? Again, this is anecdotal evidence for me, and I've gone both ways because some people say I really don't want to switch, but I've found that the chances of staying in rhythm for the first 30 to 90 days after the intervention, specifically the mini maze, are much better with amiodarone versus the other antiarrhythmics. I don't know why, but that's been my experience. And I've also noticed if someone's on a different antiarrhythmic and at the end of the procedure I cardiovert them, they're much more likely to not go back in rhythm versus if they were on amio. But that's anecdotal. You tell us what
I keep the patient on the same. If the flecainide working for them, I keep them. If Maltec working, I keep it. Sotalol working, I'll keep it.
Okay.
If there are nothing, I go to amio as for my first choice.
So we differ a little bit there. I'd much rather have them on low-dose amio for a couple months.
Beforehand.
Okay, why are there not more mini-maze procedures performed across the nation? Well, I mean, there are a lot of people that are waiting for me to go into the witness protection program right now. It's multifactorial. There are lots of little answers. I'm interested to hear Joe's comment on this as well. But personally, first of all, In my opinion, most cardiac surgeons don't know much about arrhythmias. And most cardiac surgeons don't want to. They're very happy doing aortic valves and mitral valves and bypass surgeries and aneurysms, and I was too. But I saw that there were a lot of people that were unhappy who had AFib, and it appeared that when Hassegaer's article came out, it appeared there might be a surgical approach as well as an endovascular approach. So that's how I started 23, 24 years ago. So, but really that's unusual. Most surgeons, I don't think, are very well versed in arrhythmia and arrhythmia procedures. So that's one issue. Second is the procedure that I do, I think is very simple, but it's not easy. And how do I explain that? Well, think about basketball or golf. They're both very simple. Golf even more simple than basketball. You use whatever club you want, hit it right-handed, left-handed. Nobody's going to get in your way. Nobody's going to block your vision. All you have to do is hit the ball in the hole. I mean, that is simple. And I've seen people who've watched golf on TV and they go, man, I'm going to go out and just kill this. And they can't hit the ball. So it's simple, but it's not easy. And I think surgeons make that mistake. They see it being done on a video, maybe a video of mine, and they go, oh, well, that's simple. I can do that. Well, it's simple, but it's not easy. A third thing is that many heart surgeons are not comfortable operating without doing a sternotomy, without going through the breastbone, and without being on the heart-lung machine. So when you say, well, we're not going to go through the breastbone for this procedure, some of them go, forget it. And then you say, we're also not going to use the heart-lung machine. About 45 of the other 50 go, forget it. So it's hard to find people that really take a liking to it. The good news is that we have some young surgeons here in the group that seem to be interested in it. So the jury's out on that. The third thing is most patients are evaluated by the medicine side when they have AFib, and they're naturally going to go see a cardiologist, which is fine. But if the cardiologist has associates that do EP work, they're more likely to send them the EP way. That's just natural. So I think it's multifactorial. There are lots of different reasons. Surgery is seen as a much more invasive way of doing things, and on the skin it's much more invasive than a groin incision, 100 times more invasive. But I can argue on the heart it may not be that much more invasive because I'm just making lines, not burning a lot of tissue. But I think all those are factors, and maybe there are more, but those are some of the ones that I've thought about.
Yeah, but they want to ask, why don't you have a Wolf Fellowship, for example, where you train young doctors do what you do?
Yeah. Well, I've gone around the world trying to help people do this procedure. I've been to China 18 times, Japan 24 times, Europe, I don't know how many times, South America, Scandinavia, and there are some that do it, and I guess my best student, if you will, my protege, is in Tokyo. And that's Dr. Otsuka. He calls it the WO procedure, Wolf Otsuka. He's done more than 2,000, and he's unfortunately found the same thing. He's gone out into areas of Japan that teach other heart surgeons how to do it. And he said, Randy, it's not easy to teach this procedure. So it's not just the United States. I think it's the same, and it's for some of the reasons that I've mentioned. But I do see some light at the end of the tunnel, and we have some promising young physicians here. One who recently joined us, who trained at Mass General from Harvard.
I met him,
and he seems to be interested in it. So we'll see. What is the best test to have to see if you have a thyroid problem?
The basic ones are hormones called TSH and free T4. Those are the basic ones to screen. Then there's other ones. There's the total T4, and there's free T3, and there's antithyroglobulin. There's so many other stuff we can. There's also an ultrasound, but it's not recommended to do ultrasound unless you feel a nodule.
So mainly it's a blood draw. It's a blood test.
Yeah.
Pretty simple.
Very simple blood test, actually.
If you're really concerned,
TSH
maybe you
and
should consult an endocrinologist to decide,
yeah,
or a cardiologist.
Start with the primary care. I mean, it's very simple. It's like you test your cholesterol, test your thyroid. There's no CT scans or ultrasounds or anything for a baseline.
I have an allergy to iodine. I had an IVP. I guess that's for a kidney issue. IV pyelogram is what it stands for, intravenous pyelogram. And the arm swelled 3 times the size. Now, there are 2 reasons your arm swelled 3 times the size. One is maybe it infiltrated, because usually when you get an allergy, it's your whole body, not just your arm. So this could have been a local problem. If not, then, and if it's a true allergy, well, then you shouldn't have IV dye that has iodine in it. There are alternatives. There are also alternative scans. There are MRIs.
Correct, but and let's say they need a car stent.
Yeah.
And we need to do it. So we pre-medicate. We use antihistamines and steroids. And there's a protocol 13 hours before, 6 hours, and 1 hour before. And we rarely get anaphylactic reaction after this. The body is prepared to suppress this allergic reaction.
It smells a little bit like maybe it was a local problem and not an allergy.
Well, for one arm, maybe, but unless they have it more than once. If that same reaction had it more than one test, then it's unlikely to infiltrate more than once.
Is there a tendency to develop flutter after mini-maze, and if so, why? And how difficult is it to correct through an ablation? Well, the first part of the question I'll answer. I think the answer is yes, and it's particularly more common in patients who've had multiple previous interventions. I mean, I send Joe patients that have had a lot of ablations. I mean, we've had one patient last year who had 8 ablations before they came to see us at Methodist. So yes. It seems to be more common in patients who had previous ablation interventions, but I think that's a better question for you, because these are some of the patients you see.
If the way I look at it is the following: if the atrial tissue is healthy, there's no increased chance of flutter after mini-maze.
Okay.
However, if the patient had prior ablations, especially not only where the veins are but elsewhere, there's higher chance of having flutters, not necessarily after the mini-maze, just having flutter, because the flutter happens from circuits in healthy and unhealthy tissue that's enough to entertain a circuit. Now, generally speaking, if you have AFib, you have 30 or 40% chance of developing typical right-sided flutter. And the other way around, if you are diagnosed with flutter, you have 30 or 40% chance to have AFib in your lifetime. And what I trained, the one study we're doing is putting a loop recorder for every CTI flutter we do. And
so explain CTI flutter.
CTI flutter is
it's right-sided.
It's a right-sided typical flutter. And a lot of them, I forget the number, end up developing AFib after 3 years, 2 years later. And that was the results.
Yeah.
It's not the mini-maze that creates the flutter.
No, and the and also we should point out the mini-maze did not address problems with the posterior wall, around the valve, the mitral valve.
None of that.
It doesn't do that.
Correct.
You can address that.
So that's where the catheter go and the mapping, and that's what we do in electrophysiology, because we can go point by point. The mini-maze is more anatomical and it does excellent job at addressing the AFib problem with the veins and the appendage.
And I think, in my own opinion, one of the reasons is because there's something to add on the epicardial side, which is where a lot of the nerves are. And if you can kind of decrease the overall autonomic milieu that's affecting the heart, I think sometimes that helps. It's sort of like decreasing your stress level and seeing less AFib, because I think some of it's triggered by the autonomic nervous system.
Yeah, possible, yeah.
Would you recommend proceeding with conversion and ablation while waiting for a mini-maze?
Conversion, yes, for sure. Ablation is yes and no. Depends what's the wait time, and it depends what kind of surgery, what's the problem is, how the AFib, persistent, paroxysmal, whatever. It depends how symptomatic and responsive to the medications too.
So I might answer, well, are you on amiodarone?
Yeah.
Start low dose amiodarone, wait 8 weeks, get a cardioversion.
Yeah. A cardioversion is very easy. Anyone can do it.
And if it works, then just settle down, and then you can still make your decision. You can go either way.
Yeah.
So I would take it step by step.
There's so many factors, like this question, because people compare those answers. Depends, on your stroke risk factors.
Yeah.
On
or maybe you've already had a stroke.
Yeah, or tolerance to anticoagulation, tolerance to antiarrhythmics. How symptomatic you are in AFib. Do you barely feel it, or are you in the ER to get cardioverted?
Are you incapacitated?
Or incapacitated every time you can't function, you can't drive, you can't work. So that changes a lot, the answer to that question. I mean, this is such a general question.
Yeah, totally. I'm a 35-year-old male in stable AFib. I recently found this out and have not had any treatment yet. Would you recommend Wolf Mini Maze? What is the success rate? Well, I think we have different, we need to know more. But generally speaking, most treatments would, well, I'll let you take that. You should take that first.
So AFib at 35-year-old?
35, no treatment, but we don't know if it's paroxysmal or persistent or continuous.
Yeah, we don't know, but
let's assume it's paroxysmal.
My experience in 35, in general, they have a genetic component to it to show up as very early. So I'm not sure if it's symptomatic or not, but I recommend to have the brothers be checked, because I have 2 families just like this. They found out they have AFib because one of them found out. 2, because of that early onset, is usually much more difficult in general. It's not as easy to control. We still use the same medications and the same techniques to treat it, but what I'd recommend is to early on seek treatment. By that I mean ablations or mini maze. Why? 10-15 years ago, we used to say it doesn't matter if you have AFib or normal rhythm, just don't go fast and you will not have a heart failure. And now we know for sure that with ablation we can restore normal progression, basically, or an aging of the heart, and we normalize the curve toward progression to heart failure. More importantly, if you have AFib for a while, you're at 2 times the risk of having dementia and everything down the line. So it's very clear in the last 2 years, we have a lot of evidence that the earlier the better we address rhythm problem and better with the procedure rather than medications. So at the 35-year-old, it should be addressed and not just, saying stable and asymptomatic.
I agree. I've done some patients who were in medical school when they developed AFib. They're still doing fine. One of them's about 9 years out now. The youngest patient I've done was 15, and I did his sister when she was 21. They had a strong genetic component that had been worked up. They knew this.
Yeah.
And they'd already had some ablations, but they knew that it was important to get in rhythm.
Correct.
Right? However you do it,
correct.
Get in rhythm.
That's my opinion.
Yeah.
100%.
AFib 1 to 2 times a month, 7 to 8 hours, last 8 years, no ablations, no cardioversions, ablation first or go with the mini maze. They're really trying to pit us against each other, aren't they?
Yeah.
Well, we don't want to do that.
Either way, it's fine. Either way, it's fine. There's no right or wrong for any of these questions.
Again, it goes back to they should ask the questions we just posed. Are you incapacitated? Do you tolerate anticoagulants?
Yeah,
do you want to get off anticoagulants? Yeah. Are you a construction worker on a ladder every day? That's different from someone who has a desk job, probably.
Right.
Or are you a cyclist who cycles 50 miles a day? Well, maybe you shouldn't be on a blood thinner. But
correct. It depends. So everyone has the different risk factors.
Oh, here's a good one for you. You can read that one yourself.
What does Dr. Fahed think of pulse field ablation? So it's a great new technology. So as you know, right now there's 3 different ways to ablate endocardially: the cryo, which is freezing, radio frequency, which is the heat, and now the electricity, pulse field ablation. And now everyone is so excited about it because it's the newest thing. Initially, it was promising. Why? because we thought will decrease the complications, which are very rare, extremely rare, the esophagus fistula with the radio frequency or with the cryo. It turns out it does reduce it. It's very specific for the atrial tissue, but have its own side of complications, something like coronary spasms and other stuff. That being said, the other advantage is the procedure is a little faster, and people are bragging how fast they can do an AFib ablation in and out within 40 minutes or 60 minutes. Here's my take on this, on the PFA. This is the first generation of the technology of the catheters. There's people, us, we don't know, we're still learning basically on it while doing it. The second generation is within reach. Within a year, we're going to release the next, catheter. Number two, the current catheters we have, they only work on the vein. So for paroxysmal AFib, someone young, I think it's not bad, it's a good idea. But for someone who has a Flutter, multiple ablations in the past, you need the mapping, you need the point by point, you need to, they don't have more advantage than the regular one. So the evidence is as good as a radio frequency ablation right now.
Well, yeah, I looked at the midterm results and they looked the same. I know they were hoping they would be much better than radio frequency, but they were about the same.
Correct, they're exactly the same, so just faster, that's the advantage.
Maybe it's because it doesn't hurt the nerves. Maybe you do need to hurt the nerves a little bit. Some nerves.
Yeah, that's based on your experience, which those vagal innervation of the veins and everything. Possibly.
Now, I've been using it in the lab, and we've used it with the clamp too. We're looking at all this. And it's amazing. There are like 1,000 different parameters you can change.
That's the other thing. We don't know what's the right parameters, and they're all they're proprietary, obviously, for the companies.
Yeah.
But you change one parameter, and the whole thing may change.
I know.
And also,
it's not easy to figure it out.
In the EP world, we are excited because what is the role of PFA in ventricular cases, ventricular tachycardias, PVCs? How deep can it penetrate into the myocardium, into the atrial or ventricular tissue? There's so many unlimited potential. We're excited about it. I just see we're way too early. This is like PVI back in 1990 or 1995 kind of thing.
Yeah.
So in a couple of years down the line, we'll have a lot more to.
I think what we can say today, though, is it's not any worse than radio frequency. It's faster, but it's not any better at this point.
Possibly a touch safer, but definitely faster.
Yeah.
So we used to do, I do two ablations per day. Some other EPs right now can do 4 or 5 with PFAs. But again, they're just limited to the veins, and there's more to the AFib than the pulmonary veins.
The stretch of the left atrial wall due to fixed pulmonary vein triggers AFib and fibrosis occurs. Now is AFib inevitable? Seems like cancer. That's not a complete sentence, but maybe can you figure that out?
No, I don't know that.
That's hard to. I would like to answer your question, but I guess you could say once fibrosis occurs. I mean, that's what we're talking about. You want to try to treat it before you get advanced fibrosis of the wall.
Yeah.
But I'm not sure what that is. Okay. Is there any more, Mr. Producer, is there any more to that question? No, sir. Okay. Can you talk about visceral fat, especially if it's around the heart? I can answer that a little bit. I've been looking into that. There are some very interesting studies that have looked at the pericardial fat. And these studies suggest that pericardial fat is not just sitting there.
Correct.
It's very active and it gets angry. And some people postulate, it's not been proven, but postulate when the adipose tissue, the fatty tissue around the heart, which we call pericardial, peri means around and cardio means heart. So when that tissue gets inflamed around the heart, that may have an effect on the autonomic nervous system and make it go a little bit out of whack too.
Correct.
That's the theory.
There's a lot of hormones or whatever that fat tissue will secrete, and
some people think ultimately maybe the treatment for AFib will be to settle the fat down.
They tried. So they tried, post bypass surgery to infiltrate or to inject something in the fat, see if they minimize the AFib. They haven't found yet, but they can measure how much active that fat tissue is, not passive at all.
No, I think it's fair to say that fat is
it's active.
Yes,
it has it does have a role. We know signs of it, but we don't know the exact extent to it.
And these autonomic nerves, the
Correct.
vagal branches, the sympathetic
Correct.
branches, they
innocent.
penetrate all through that fat.
Correct. It's not innocent.
Would it be better to have an ablation before the mini maze, try to get rid of AFib? Well, we sort of touched on this.
Story.
We need more information. For some people, yes, for sure. For other people, well, maybe not. What's your problem? Have you had 3 strokes? Well, you could go Watchman and catheter ablation, or you could go mini maze.
We're gonna see more of what you mentioned. Medicare, as of today, actually approved the Watchman and ablation as one procedure. Before, they would not reimburse the hospital.
That's right. Today starts
October 1st.
The new DRG, right?
The new DRG, where they lumped these 2 codes together. So these patients are gonna see a lot of their physicians, electrophysiologists offering, I can do Watchman and ablation, same setting.
Yeah.
And with the PFA, you can just see how things gonna evolve. Quick, fast, close the appendage, do your AFib, but and the right population, obviously. I'm not sure how quick we're gonna implement this, but I can see in the future.
Yeah. Do the specialized AV ring tissues play a role in AFib? I'm not really familiar with that terminology. Or does that make sense to you? Or?
AV ring, do they mean the valves, like the mitral area and the tricuspid areas?
Maybe.
Specialized AV ring.
Not sure about that one. We're coming up on the end of the hour. We've had a lot of really good questions. We've tried to address them. I think it would be appropriate, as you know, you can go to the Facebook site and also ask questions there. There's a Wolf Mini Maze website. You can ask questions there. Or you might want to ask a question to Dr. Fahed. Are you comfortable sharing with them anything where they can get a hold of you if they want to? You have an email or something, or an office number or anything?
I can share my office numbers, 713-791-1870. And we do televisits. I usually see the patients coming through Dr. Wolf. And
I also send Dr. Fahed cases that I've not operated on. Sometimes I see patients and their main problem is flutter.
Or SVT.
Or VT. We've seen that.
SVT. You saw on the loop, they have only SVTs.
Before I talked to you, I had a couple patients who were told they had AFib.
Correct.
And I reviewed
the data.
They didn't have AFib. They had VTAC, monomorphic VTAC, which you can help.
Yeah. It's nice to have a different perspective or second opinion as needed, especially after you suffer from what you're going through and you don't find the answers you want.
We had a patient who had 3 ablations, came here. It turns out he had a left SVC, superior vena cava, which can be arrhythmogenic.
Correct.
Treated that. For the last 2 years, nothing.
Yeah.
So there are all different types of combinations.
Correct.
I think maybe the best thing we can say is that, as what you already said, is get a second opinion from a place that has a high volume.
I didn't feel the time passing by. I enjoyed this session.
Well, good.
It was great.
Thank you all for tuning in. Of course, this will be available right after this is finished. And appreciate all the questions. We'll be back with you again next month. Is that right, Mr. Producer? We're on next month? He's saying yes. First Tuesday of the month, 5 p.m. Central Time. Until then, stay safe and watch the debate tonight, I guess. Take care, everybody. Thanks,
Thank you,
Joe.
everyone. Thank you very much. That was amazing. Thank you.